right at the moment, Kwame, for possible integrated care system representation? Yeah.
Yes, it is. Yeah.
Yeah, I thought so. So I'll just double.
It was subject to them agreeing to be on the council, but so they have to agree, and then they will nominate. Yeah.
Yeah. Okay. I'll chase that up with Rima, but I have to say I haven't heard back from Maria, unfortunately. It's quite a lot going on, I think, in terms of this.
Yeah, it's not the most important.
It's not high on the list of agenda, which is fair enough. And then item 20, this was just around the update on the child and adolescent mental health services inpatient for Beds, Luton and Milton Keynes. It's just to say that a unit has opened on the Luton and Dunstable site. That's opened in February, but it's what they call a slow launch. They're just gradually using those places over the next few months until they were up to full capacity, but there will be 8 beds. And it's only for short term, but it's for those young people who need a period of time in inpatient support. So we do actually finally now have something in the system where our young people can go if they need a period of time in inpatient facilities. So if you're happy with that, I'm sure I will hear more in some of the system meetings, and you know, anything that pops up I will feedback at our meetings. But if everybody's happy, we'll close that action. So as we know, we now have that in the system. Okay. Anything anybody else noticed that we haven't picked up on the action log at all? Okay, thank you very much. Going on then to my report. Apologies first to everybody that it came out at the beginning of this week rather than last week. Unfortunately, I went on annual leave last week and hadn't actually written it. That was one of my oversights, so I apologise for that. Just to say, really to pull out from the report that obviously we had a CQC inspection of our maternity services, which actually overall went well. Obviously they did pick up on a few things they wanted us to address, but no serious concerns. And also we got some good feedback as well. Particularly, in fact, one of the issues that jumped out at me was around our training for home deliveries, that our nurses are actually training in a house, as opposed to doing a mock-up in a room, which is never quite the same. So the CQC picked up on that and thought it was really good practice. They could share that around to others. So obviously we're waiting for the full report, but it's likely to be delayed because unfortunately there's also industrial action with the Care Quality Commission, as well as obviously other areas in the NHS at the moment. So unless anybody has any questions for me from my report, it's really just to update you all.
Just one small comment, slightly light-hearted. You've already downgraded Dame Anne.
Oh, no.
That's the High Sheriff of Buckingham. It's actually Buckinghamshire.
I missed something. I beg your pardon.
You've got the rest of it.
That was a good point. Yeah. No, she did a fantastic speech. Actually, I have to say, she was really quite inspiring. Actually, well, so. Oh, were you there as well? Yeah. Sorry, I was at the back.
No, that's a great job for.
Yes. Yeah.
The council.
Yes.
As well as the city.
Not just the city, no, absolutely. Thanks for that. Okay, now Chief Executive's report. John, do you have an update from Joe's perspective?
Happy to give one. Yep, sure. Firstly, to report back, of course, between just after Easter, we had the junior doctors' strikes, and that passed off reasonably well. I don't know what you can say about it, really. I think the appetite from senior doctors is every time this happens a little bit less. And it was a difficult time because obviously a lot of consultants had already booked leave off for Easter and time with children, etc. We don't have any dates yet for further strikes, and of course it's unclear what's going to happen in terms of the nurses' ballot. That's way above my pay grade, so we'll have to wait and see what happens nationally. I think Milton Keynes has been in the news over the last week or so about some of our waiting times, which are recognised as being too long. This is certainly going to be one of the things that we're going to try and prioritise this year, to try and get back on top of it and improve the shape of the waiting list curve. On a more positive note and related to waiting times, we had a paediatric super day for children who needed planned surgery. So we dedicated the whole of the a phase 2 operating theatre complex, 2 paediatrics for 1 day. We plan to do about 46 cases, 46 children, which we cracked through. I think there was just 1 child who arrived and was unable to proceed to surgery because they had chickenpox. And we definitely don't want to have that in the building. But other than that, it went off really well. It's a really positive experience, and it was witnessed by NHSE senior members of staff. And I think it's going to be recommended as good practice, because a lot of smaller hospitals that don't have sort of dedicated children's hospitals struggle to separate children and adults in theatres, and this is actually a really good way of doing it. So I think we will try and repeat that again and again. And just lastly, for those of you who've managed to walk around the site recently, you will see the radiotherapy building going up. And it's on budget, on time, and is I think the building's doing a very good job, nice, clean and tidy. And so that's expected to open or to be finished anyway in sort of probably May of 24. There still isn't, and I think Alison raised it with the Oxford chair, we still don't have a solution to the purchase of linear accelerators or planning CTs. And so that's very much an ongoing and live conversation. But that's it from me, unless anyone has a question.
Thank you very much. Any questions for John? Keith.
Thank you, John, for that. Very interesting about the paediatrics day. Are there any other, I suppose, specialities which could benefit from having a day allocated them to crack through and, as you call it, and reduce the waiting list significantly?
So the interesting thing about paediatrics, of course, is they aren't one specialty. So you've got orthopedics and ENT and lots of different specialties operating on children, which is why it works so well. Generally speaking, for the other specialties, there is a limit, usually by the number of surgeons and specialist theatre staff, that would limit our ability to take that sort of approach. But it works very well for children.
Thank you for that clarification.
Thank you. Anyway, thank you very much. Thanks for that, John. And I think you're down for the next one, the capital programme update as well.
Yes, happy to take this. There is a paper. I think we haven't yet bottomed out. If Terry was here for the finance report, we haven't quite bottomed out the amount of capital that's going to be available to us in this year. And there is currently a potential shortage of about £5 million. All the projects which are, if you like, leftovers from last year are proceeding well and are mostly finishing. The one exception is possibly the multi-storey car park, which actually isn't a capital scheme, it's a revenue scheme, because we, by undertaking remedial works, we only expect to take it back to where it should be, if you like. It's not an improvement. And currently, with the costs that we have of circa £1.5 million required to spend on the top deck, we don't have a way forward. We are awaiting a legal opinion because we did raise this under the warranty period, so we're hoping that we will get some ability to reclaim off the original builders. I'm very happy to answer questions on all or any of the capital programme items there.
Thank you very much. Thanks, John. Any questions from anybody at all? And hopefully everyone finds this useful. Obviously, it just keeps you up to date with all the plans, and also, obviously, we need to let you know if, as John says, sometimes it's a question of trying to get the funding, which can be a bit of a challenge at times. But I'm sure we will do another update further on in the year, just to see how things are going, particularly around, I'm sure, around radiotherapy, because that is cracking on at pace, and we want to get that completed as soon as we can sort out the equipment to go into it. If everybody's happy with that, thank you very much. Thank you, John, for that. Going on to item 9 then, this is one of our subcommittee updates. Heidi this time from our Finance and Investment Committee. Obviously, hopefully everybody's had a chance to read the paper. Heidi, is there anything you would like to particularly draw out from this?
Sorry, I'm coming. I couldn't, after all these years, you think we'd all be good at it. So apologies not for being there in person, but I'm full of germs, so I think you'd probably prefer me not to be if I was sat in the room. No, I think the report kind of hopefully lays out the considerable amount of work that the whole team across the hospital have undertaken in the last year, and particularly in terms of the finance team, to make sure, I think, that we are spending our money well and that we are doing everything we can in terms of how we use our budgets. But I think I really hope it shines through how challenging the year has been, but also that with the year that we've just had, or we're having in 22-23, that the challenges that really lays down and sets down for the year to come. So where we have achieved improvement in our performance, we've obviously spent money to do that we thought we would then be getting in terms of ERF funding at the end of last year. And that was then changed, so that money's not coming through. But obviously that means we're then starting this coming year from our base performance. And we haven't got that funding sat behind it. So I think, you know, I don't know who's in the room from finance. I'm trying to have a look if Terry's there. I don't want to say something that Terry wouldn't say, but I think they're working incredibly hard to try to make sure that we're in a position where we can be still delivering our plan, because we have delivered our plan over the last several years. And I think it's fair to say there's pressure on most of the trusts across the UK for the coming year. But I think we've done some fantastic work, and I think particularly for the hospital, and John's just commented on it, and John is a big lead in this, that the capital programmes we've delivered are excellent and continue to improve the infrastructure and experience for the patients of the hospital. So I think there's lots of good things. I'm happy to take any questions if I'm able to answer anything.
Thank you very much, Heidi. Thanks. And thanks for being online. You're feeling rough. That's much appreciated.
I just think it's not very nice sat in a room with loads of tissues, and it doesn't seem very...
That's absolutely fine. Anybody, any questions? William?
Yeah, I mean, Heidi, one of the critical risks you highlight, obviously, is the workforce availability. Now that clearly has sort of two sides to it. One is the kind of industrial action and the impact, and there's very little that we can do about that. But I think one of the things that the trust have been very good at is providing real support to staff in order to kind of help with the retention. Are we in a situation where we can say actually how well are we doing perhaps compared to other trusts in that? Or is that something that we don't have the data for?
I probably want the answer to that. So I think our turnover saw an increase post-pandemic, which we expected and was moving across just lots of other sectors as people started to move around. It started to come down again. Our staff survey results are some of the best in the country around some of those elements. I think it's hard often to really sort of compare and contrast with those sort of blunt things like turnover. Yeah. But we do compare well. I think for us it's going to be about how do we keep making sure that we are responsive and agile to what staff need. Across the whole attention sort of spectrum. It's really in terms of support cost of living and what happens next with industrial action and career progression and pathways. Around diversity and inclusion, so all of those things I think we've got a big programme of work that we need to continue to deliver. I suppose that when there's changing pressure in the external environment around finance, we want to make sure we're still able to do that in that environment.
Yeah, and obviously one of the other things we can't control is the agency costs in these kind of situations. So are we more or less on track with that, or are we already over?
Off the top of my head, I wouldn't like to say, but no, I don't. I'm not entirely. I mean, it's something we can come back unless John has got an answer to that at all. Otherwise, John.
So happy to say we've had lots of conversations about premium rates for staff, and we are beginning now to wind back some of the winter premium rates for staff. As we find fills a little bit easier. So most of our additional staff costs are certainly for nursing, not really agency, but they're bank shifts. And so we've over winter we had to pay enhanced bank rates to get people to work to cover the shifts, but that's not financially sustainable. So we've been winding back on those, reverting back to normal bank rates, which we'll do in 1 or 2 hops up to, I think, the middle of next month. And that will begin to reduce the costs of bank staff. And that's, of course, particularly helped by getting all our overseas nurses in here working, having passed all their OSCEs. That helps enormously. So we're looking to reduce our expenditure going forward.
Yes, because I mean, obviously we're going through the accounts now, you know, for the year end and everything. So I think the ambition is we keep them as low as possible, but realistically, you know, when we're facing strikes and all sorts of things, it's a question of managing. You know.
Inevitably, it's going to be over.
Yeah.
The question is sort of how much and what impact will that have on other plans.
Yeah, no, absolutely. So lots, as John says, lots of work going on to try and minimise it. And obviously we like to use our own bank staff rather than agency as far as we possibly can. Any other questions at all for Heidi or anybody else? Okay, thank you very much. Heidi, thank you very much for that. We'll leave you alone now. Right, going on to, we come to Kat and Sam. Welcome again. From the Alzheimer's Society. Thank you very much for agreeing to do a presentation for us today. Really appreciate it. And obviously we've thank you for the slides in the pack, because that's really, really helpful. And perhaps I can hand over, I don't know who wants to start, but perhaps I can hand over to you. And Julia, are you doing the slides?
I can only do it on here. I wonder if Kwame, could you bring the presentation up?
Yeah, for those online, Kwame. Thank you very much. Perhaps we'll just hang on for a second until that's up, and then whoever's speaking, perhaps if you just let us know where you want us to move on with slides, and then Julia and Kwame will coordinate, I'm sure.
Lovely. I don't think I've been in the position of next slide, please. So this is very exciting. So I'm Kat. I'm the area manager, and I cover Berkshire, Buckinghamshire, Oxfordshire and Milton Keynes, and we've yet to come up with a catchy title for the patch. I've only been in post since January, but I've really enjoyed getting to know all the different work that happens, especially in Milton Keynes and in Milton Keynes Hospital. Sam is my colleague. Sam is the service manager that covers Milton Keynes specifically, and she has 2 services she runs here that I'm going to touch on shortly once the slides have been shared. We're really grateful to have this opportunity to come and be in front of you. Dementia is a growing problem for nationally, not just the population of Milton Keynes. And on one of the slides, I'll show you some fairly sobering statistics around what dementia really looks like in Milton Keynes. Have the slides been able to be shared yet, Kwame?
I'm downloading it. I'm downloading this.
Because I can share my screen if that's easier. I've got
them
on my screen. So if you just bear with me a second.
1 minute.
For anybody who's got the papers on there, if they've got a laptop. Yeah. It's a race as to who manages to do it first, isn't it? Somebody's Kat's done it. Well done.
Lovely. So hopefully that looks all very sensible, because I've almost lost you all now. So as I say, I'm Kat and I'm the area manager. I've been with the Alzheimer's Society for over 7 years now, and I've worked with people with dementia for coming up to 20 years, in fact. So it's something that I'm really passionate about, and I think more and more we're all being affected by knowing people with dementia, being concerned about it in our future, or caring for a person with dementia, or experiencing it ourselves. So dementia in Milton Keynes.
Sorry to interrupt you, but we can see the next slide as well.
Okay.
You're not sharing
that's
it.
strange.
Yeah.
My apologies. And that show.
You want me to do it from here?
Doing.
Can you stop sharing so I can do it from here, please?
Yeah, of course. There we go. See, it was all going so well. Thank you, Kwame. That's really helpful. So as I was saying, in Milton Keynes, there are currently 1,791 people with a diagnosis of dementia. But what we know is that actually not everyone is diagnosed with dementia for a variety of reasons. So the diagnosis rate is currently 67.1, which is actually above the national target, which is 66.7. As Alzheimer's Society, we would suggest that diagnosis rate target needs to be significantly higher to enable those people who have dementia to actually gain the care and support that they require. I think the thing that for Milton Keynes that is one of the most sobering statistics is actually by 2030, people in Milton Keynes living with dementia will have more than doubled, which means it's going to be a significant problem for health and social care and for primary and secondary health services. The annual cost of dementia care in Milton Keynes is £113 million already. That's a significant amount of money for actually what makes up less than 1% of the population. And it's expected to rise to 213 million by 2030. There are a significant number of unpaid carers in nationally, we know that, and we know that there certainly are in Milton Keynes. And more than 30% of unpaid carers spend more than 100 hours a week providing care for their loved ones. I think you'll agree that's quite sobering statistics, and we're in a position where at the moment we don't have a cure for dementia. So what we need to be doing is shoring up the services for people with dementia to make sure that they can have the best support that they can get. So what does that mean for the hospital? Well, nationally, we know that 31% of admissions for people with dementia are for 1 day or less, which implies that what's happening is that people aren't able to access GP surgeries in a timely fashion, or that their symptoms are actually allowed to progress to a point where they need a short-term swift intervention that may have been better provided in the community. We also know that readmissions of a person with dementia is 62%, which is higher than the general population, and it costs 15% more to care for a person with dementia than it does for a person without dementia. I had a look through lots of studies before I did this. I wanted to make sure it came across as making sure I knew what I was talking about. And something that really took me aback was actually if we just prevented some of those short stay admissions between 2015 and 2020, we all know nobody talks about 2020 to 2022. There's no point talking about it. But £326 million nationally could have been saved over that 5-year period, which is an astronomical amount of money that actually could be better spent in social care or in front door services, preventing those people coming through the door in the first place. We've all worked with people with dementia, and we know that generally admission into hospital is fairly catastrophic for them. It's very rare that a person with dementia leaves hospital with the same abilities as they went in, and can take a period of rehabilitation, a period of recuperation before they are able to either regain some of those skills or they find a new plateau or baseline. Next slide, please, Kwame. So we are Alzheimer's Society, and we are a national organisation. But we have commissioned services within Milton Keynes. So Sam manages these commissioned services. She manages the Dementia Information and Support Service contract, and she manages dementia friendly communities as well. Next slide, please, Kwame. So the Dementia Support, or the Dementia Information and Support Service, also known nationally as Dementia Support, is for the dementia advisors who are trained to deliver support, guidance and information about all aspects of dementia or caring for a person with dementia. So we know it can be really isolating after your diagnosis. It can feel very overwhelming. And unfortunately, diagnoses are delivered in a way that mean that people aren't automatically funneled into a system. So we're working to reduce that. We work very closely with the Memory Clinic in Milton Keynes to make sure that people who need support are able to access support in a timely fashion. But what we can also do is offer at any stage of your diagnosis of dementia or your experience of the disease is support to understand your current symptoms or your future symptoms, to reduce your isolation. So we offer some services around singing for the brain, carers support, memory information. We can also support you to access benefits and assessments, and we can support you to discuss your plans for the future. A common theme is around supporting people to understand when it's appropriate to access healthcare and how to advocate for their loved one whilst they are in hospital. We know that's something that people can really struggle with. Our dementia advisors are also, I mean, they're all excellent, but they can also signpost to partner organisations and charities for help and support. We are experts in dementia, but what we're not always experts in is things like the benefits that you are entitled to. So we link with Citizens Advice. There are lots of social services supported by Age UK that we signpost people to. So we try and work collaboratively with our partners in Milton Keynes. I've included our contact details there because what I never like to do when I present to a group of professionals is presume that actually you're not currently being affected by this. And so if anyone requires support or information, then you can contact us via those contact details. Next slide, please, Kwame. So our dementia advisors, we have 4 of them managed by Sam, and they support the residents of Milton Keynes who have that diagnosis or caring for that person with dementia. And what that can look like is some really light touch intervention, maybe some information, a fact sheet, some support, one of our guides, just having a conversation about it. But it can also look like some really intensive support to enable you to live successfully, to be able to continue doing the things that you would like to do, to support with safeguardings, to support you to access the things that might make your life easier, direct you to adult social care or occupational therapy. And no 2 days, I think the dementia advisors would agree, are ever the same. And we're always learning as well. The thing about dementia is if you've met one person with dementia, you've met one person with dementia. So while we can have a broad spectrum of information, there will always be something that challenges us on a daily basis. Kwame, can I have the next slide, please? The other service that Sam manages is the Dementia Friendly Communities, which is currently run by a full-time member of staff called Anne Louise. Dementia Friendly Communities is around improving inclusion and quality of life for people with dementia by enabling communities to think about the way that they approach people with dementia. We've had a huge uptake from different organisations, including Thames Valley Police, the parish councils, Milton Keynes Council. We've also had schools, scouting units become involved, and something that anyone can do, and I would encourage you all to do as the Council of Governors, is to become a dementia friend. You can do it online, and it's a really short video that you watch, and gives you some really helpful and useful information to support you to deal with people with dementia and support them and make them feel included in the local community. We can also offer, before I take the words out of Sam's mouth, a Dementia Friends session if anyone would be interested to be delivered to the Council of Governors. Anne Louise can deliver that, and then you get to walk away with a little badge, which is always very handy. So if that's something you'd be interested in, or you feel that you know a team that would be interested in that, then please do use our contact details to let us know. And then finally, I thought it would be, sorry, Kwame, next slide, please. I thought it'd be really helpful just to flag the things we do as a national organisation. So Alzheimer's Society has a national dementia support line. So if you're sat there thinking, I know someone who lives in an area and I'm not sure they are, or they're not within Milton Keynes, they can contact the National Dementia Support Line and they will be directed to their local services, or they can have some information sent from there. We have an online community, which is really, really fantastic. It's called Talking Point, and it's a forum with which people can access our services in terms of its peer support, but it's moderated peer support. So all those times I want to give someone a piece of advice that perhaps needs that slightly more personal edge, I direct them towards Talking Point, because there'll always be someone in there who is able to support that. And actually it's moderated 24 hours a day now. We have moderators in Australia and Canada, so we're able to run that on a 24/7 service. We have a myriad of fact sheets and publications. Any concern or worry that you might have linked with dementia, or any information you would like, is all available on our website. And then the last two things I think is really key for me to to flag to you is we do a lot of campaigning for people with dementia, and so we often produce different papers around what we have been informed by people with dementia would be most beneficial to them, and how we would like the government to change things, the funding. As you can imagine, we are part of a large queue of people asking the government to invest in different things. But what we know is that if we can shore up what we do for people with dementia in the community, is we can do things like reduce their hospital admission or make their stay shorter, which I think is really important. And then finally, we do research, and we funded research for over 30 years now. And I'm hoping you will have all have seen recently in the news some information about lecanemab, which is a new drug that's coming. And the most important thing about these new drugs is what we need for people to do is get diagnosed early. They are most effective at prolonging your ability to maintain or reduce your symptoms the earlier you are diagnosed. And we know that often people wait until they are much more advanced in their dementia to have what we would call a barn door diagnosis, where even the milkman knows they've got dementia, but they've never got that official dementia. And what that does is that excludes them from being able to have these new drugs that are coming through. This is the first new effective drug in 26 years. So it's really significant. And what we need to do is we need to reduce that stigma. You might have seen some of our campaigning around, it's not called getting ill, it's called getting old. No, it's not called getting old, it's called getting ill. I need to get that around the right way. Because actually, memory loss and the symptoms of dementia are not a natural part of aging, and there are things that we can support you with, but we also need to acknowledge that it is an illness, and we need to make sure that we're supporting people appropriately with that. And then the final slide, Kwame, is our publications. So I just wanted to flag a couple of these to you. They're not particularly light reading. I would suggest you probably don't you're not going to sort of pick this up when you're on holiday, if you're on a beach in Barbados or anything, but it's really interesting, some of the recommendations we make, especially from diagnosis to end of life. We have some recommendations for hospitals around how we support people with dementia and their carers to have a successful stay in hospital and to be discharged well. Lots of it is around the fundamentals of communication, but we also have some resources that we use, for example, a This Is Me document, which gives us information about the person with dementia to enable them to be calmed or to have someone have short, meaningful interactions with them. Most of the dementia statistics I've pulled out today are also available from the link on within this slide under local dementia statistics, and that pulls out information around that's collated across the ICS for BLMK. So if ever you're interested to see what your dementia statistics look like, then they're all available there via our website. So that's everything from me in terms of the presentation. If anyone's got any questions, I'm happy to take them.
Thank you very much. That's really, really helpful. A really clear presentation as well, Kat. Thank you. And thanks to Sam for being there as well. Any questions from colleagues? Yeah, that's it.
Obviously, patients with dementia can be staying or visiting across the hospital, and I was just wondering how the hospital worked with Alzheimer's Society to work towards or ensure that, you know, the wards and the hospital site is dementia friendly, as Milton Keynes has kind of pledged to be a dementia friendly city. Interested to see how that work progresses.
Yes, yeah, absolutely. I mean, Kat or Sam, perhaps. I mean, any direct contact you have with us? So, I mean, obviously we've heard of things at the board in terms of our nurses working with various colleagues around training. I think it's probably something that can be needs to be expanded and built on. But yeah, if there's anything that you both like to let us know around the hospital in particular.
So we don't have any direct contact with the hospital at the moment. It's actually sat on mine and Sam's list of things to do, because Sam and I are going to solve all the problems of the world. But actually, we would really embrace being able to work. We see the most effective way of working with hospitals is actually working with the staff on the ground, is being able to give them that information, but also be able to support them with the tools, some of the tools that we have available. But it's that understanding of how to support carers especially, and we know that you work with Carers MK and Age UK, so we're looking to partner with them as well to make sure that we can support sort of in a more holistic way. We want the person with dementia to be at the very centre of it, but we would absolutely welcome any interaction with the hospital in terms of offering our support where we can.
And I second that, and would love to be able to work with maybe the discharge team. So look, when someone with dementia is being discharged, we know everything's in place and they can be referred back into our service, maybe as part of that discharge from the hospital. That would be a wonderful way forward to give that person with dementia that support moving in and out of hospital.
Yeah, I was just going to say two things. With good fortune, Health Watch Milton Keynes should be starting a piece of engagement work with patients around the system flow priority for Milton Keynes deal, and that will involve sort of discussing and engaging and running some case studies and workshops with patients and voluntary sector and staff within those services, including the hospital, around that admissions avoidance, discharge and avoiding readmissions. And I've been thinking, as going through this presentation, it would be really essential to get feedback from Alzheimer's Society and have you involved in that feedback and that process, because I think it could really add value. The second thing I was going to say, the hospital are starting to resume place assessments. And I know when I've been involved in place before, I think it was the deputy chief nurse back then. This is prior to COVID times. I don't think he's on with the organisation anymore. But we had quite a look at things like how dementia friendly some of the areas in the hospital were. So I think it is something that could be picked up, and perhaps if there are local volunteers around the dementia friendly communities, the hospital could reach out to those groups to get them involved in the place assessments, perhaps be incorporated into that element, and then it's got a nice structure into kind of action plans and things within the hospital.
Maybe that's really helpful actually, and I think apologies, I realise our exec colleagues, that so many of them covered over the strike periods that they missed out on annual leave, so that's why we're a bit thin on the ground at the moment, so apologies for that. But I will pick this up actually with exec colleagues, because I think we need to this is certainly an area we're already working with, as you say, with Age UK and Carers Milton Keynes, and this just seems like another plank in that sort of foundation that we need to really get the services to where they need to be. So I will certainly pick that up. Perhaps we'll put it on our action log as well, because then we'll get some feedback from the exec team. I mean, I do know, just talking to certainly one of our nurses around our patient experience lead nurse as well. Certainly we've had conversations with her around all these sorts of issues, particularly older and frailty. But actually, it seems like a golden opportunity really to work with you much more closely and really get that teamwork built up. But I will pick that up with colleagues.
That's great, thank you.
Yeah,
and
I think that's really important, just to kind of reinforce that, clearly, as you said, Age UK, we're already, having that kind of connection.
Yeah.
And I think it'd be really helpful to make sure that Sam had the name of someone to talk to, so it can actually be followed up. So that's the first thing. I suppose that the other point I wanted to raise was just the whole kind of thing like funding, how challenging it is in third sector. And I just wanted to have some kind of understanding of how you're funded for this service. Is it adequate? And, I think one of the other challenges I know is that sometimes contracts aren't maybe yearly, and therefore the whole kind of issue about planning. So maybe you'd like to comment on that as well.
Thank you. So we our Dementia Information and Support Service is paid for by Milton Keynes Council, as is the Dementia Friendly Community Service. That's currently on a year-long grant-funded basis, which, as you can imagine, stymies some of our best efforts in terms of longer-term planning. However, we have had a commitment from Milton Keynes Council that we will move to a tender process with a 3 to 5 year contract, which, while that runs the risk of us not being the successful partner, what we really hope to do is demonstrate that actually with that longer-term funding, we can really make a bigger impact for the people in Milton Keynes with living with dementia. And then in terms of whether it's adequate or not, the big plans Sam and I have would require a pot of money significantly larger. However, we also know that Milton Keynes Council are occasionally down the back of the sofa looking for spare change. So what we've got plans to do is actually look into how we can increase our reach and our impact. With the funds we've got, we would be looking next year to a slight uplift, but we would be looking at things like how we reach those underserved communities as well, because we feel that that's a really big issue within Milton Keynes. Is we see very few people from Black and minority ethnic backgrounds getting a diagnosis or a timely diagnosis, but that requires a dedicated piece of work that we're very conscious that we don't want to be tokenistic within that. So that's where we're going to be looking for some additional funding to be able to support that piece of work.
Thank you very much. Any other? Keith?
Number of observations. First one's picking up. We talked about place. When I went my first place tour of the hospital and learned so much about dementia-friendly colour changes and making sure that people could be seen going into toilet areas and clinical areas and looking for signs. I think it was very, very illuminating. You mentioned, Cass, about the publications. They're not necessarily a light read. I am currently reading the book called Unforgettable, which is the book about Steve Thompson, the England World Cup winner, who at the age of 40 was diagnosed with early onset dementia. And it was a very, very dark read. It's one that I'm reading at night. So, and he's very young. But the question to you is, I've got 2 friends who recently been diagnosed with dementia, both are in their 70s, but we watched the change. In terms of their family, one, the wife was thinking it, and the other, he was a widow that had a grown-up daughter. They will probably be the carers. At what point would you engage with people? Can they come to you before a formal diagnosis and seek the advice about what they could do to help? Or is it that you have been diagnosed, here we've now got the Alzheimer's Society? If you could comment on that, I'd be grateful.
Pam, would you like to take this one?
Yeah, absolutely. They can come to us before diagnosis, particularly if there's a waiting list to get the diagnosis. We've got books about tips for your memory, and we can support not just the person with dementia, but actually the carer as well. We can support them both, either separately or together as a couple or as a family. We talk quite openly about advanced care planning. So look, for people with dementia, that's a really important element, because it's important for them to think about that before they lose capacity. So it is important to talk about that at an earlier stage. And even the NICE guidance say, you know, giving early and ongoing opportunities to discuss that. So that is something that we do with anyone that comes along. We absolutely are there to give emotional support just as much as we give practical support as well. So we're there for whatever they need. Please do give our contact details to your friends.
Thank you very much. I'm sure they're probably already engaged. Because there's Carers MKs, another care group. I came across one only yesterday, Carers for Carers, which in my role as a counsellor, someone wrote to me. I've not heard of them. So it now appears to be 2 caring organisations specifically to help carers. But of course, all the societies like Alzheimer's and those related to individual clinical conditions. So I think it's a bit of a minefield to find the right place to go to first. But I think you're very clear that what I can share, if necessary, but also anyone in the hospital can do the same. Thank you very
Not-
much.
Not only do we offer one-to-one support, we also run some online carers groups. And I think for people who are caring for a loved one with dementia, the key thing is actually to have that peer support where they can say, actually, I've been in this situation, this is what we did, or this is what happened to me. That is a value that they get out of those groups, as well as having a dementia advisor facilitating that for the practical support as well, and to inform them about the different publications that we have.
Thank you very much.
Thank you.
Oh, yeah, thank you. I'd like to echo what Alison said, that it was a really good presentation, and I'd like to sort of extend our thanks. But I'd be keen to explore your offer for the presentation on dementia claims and things like that, and so that my colleagues and I, when we carry out place audits, we are in a better position to be able to be useful in that regard. So I'm not sure if this is something for Louis to pick up.
Yeah, I think Kwame, would you coordinate that for us, please, so that we can offer that training for governors? I think I'd raise that with the non-execs as well, actually. To be honest, I'm talking to non-exec colleagues. I think it'd be very useful because we do visits as well. So, yeah.
Julia can put it down as an action, then we can.
Yeah, great.
Yeah.
Thank you very much. Thanks. Yeah, no, I think that's really helpful. Thank you for the offer. That's really, really helpful. And that's in line with, I'll pick up with exec colleagues as well, around us working much more closely with you. We should grab you with both arms, I think, as soon as we can.
We'll look forward to it.
Any other questions at all or comments from anybody?
Excellent.
Thanks. Thank you both very much. Really, really, it's great to see you. And hopefully, I think governors are saying they're finding these, meeting our partners out there or potential partners is really useful. And it really helps with understanding so many aspects of services and, what we can do with partners to offer a broader, more holistic service actually for those that come to the hospital. So thank you both very much. And I'm sure we will be seeing you again.
Thank you. Thank you very much for having us.
Excellent.
Okay, going on to item 11 then, membership and engagement managers reports. Louis, can I hand over to you?
Certainly can, thank you.
Thanks.
Okay, yeah, so thoughts there. Just to give you sort of a lot hot off the press, if you like, a recent update. On Saturday, I was at the Friends of the Caribbean Health Forum event with the governors Yolanda Potter and John Garner. We really enjoyed ourselves. The event was in Bletchley. We had a theme of mind and body, and we had a stall there to set up to sign up members, provide some leaflets on healthy recipes and nutritional information, which was provided by our nutrition team. And John and Yolanda dealt with various people who had a variety of queries, including 2 people who were interested in becoming governors. So that was great. And that was a really successful event. It was well managed, and we were very, very sort of happy to be there, very useful. We've been invited to the next event later this year, so that was good too. And what this event shows, actually, as well with the rest of the reports, we're making some really good progress on several fronts. Some good contacts with community groups. And there's a long list of groups that have been meeting in the report, and we've started to build those dialogues with leaders in those communities, the influential people, stakeholders as well. And we're starting to go out and meet these people face to face, be in those places where different groups gather and congregate and meet, and the fact that we're sort of showing the willing, and we'll be out there and listening to what people have to say, and being able to promote membership, as well as some clinical medical kind of information as well. And what governors do you want to be a governor? I feel that's having a really good effect on not just membership numbers and our governors' situation in terms of filling up those vacancies, but also just parts of the community that are saying that they're delighted that we're there, and it shows with our partners as well. They kind of reference that as well in their presentations, that we are in attendance and we're working with them. So that is really pleasing to see that. Finally, from me, in terms of the internal side of the trust engagement, there's a trust-wide engagement group that's currently being set up, made up mainly of internal stakeholders. Although we're still establishing the membership of it and its aims in terms of reference, etc. The idea of that is to help with coordination of all of the engagement activities that are happening across the trust, identify where there may be gaps, and just support those teams with a variety of means, and to help with their activity. So there's lots happening going forward. Yeah, that's kind of me. Any questions at all?
Thank you very much. Thanks, Lou, and thank you for all the work you're doing, and you, Kwame, as well. I know about, and I think Idris has been involved as well. So there's been lots of getting out and about, which is really, really positive. So thank you for that. Anybody got any questions for Louis on this?
One, Louis. Are you involved at all in the integrated care systems? I'm going to forget the name of the group.
Collaborative.
Now. The engagement collaborative.
Yes, we couldn't get along to the last one a few weeks ago due to annual leave, people on annual leave. But yes, we're tuned into that. So thank you. Yes.
Yeah, no, that's just really helpful, because I know one of the challenges at the moment is trying to kind of make the right connections and make the most, rather than avoid duplication, and make the most of our joint efforts. So it could be a really useful space to be involved in.
Great. Yeah,
definitely.
Yeah,
thank you.
Brilliant. So another plank to build on. That's brilliant. Thank you very much. Any other questions?
Just asking on the other engagements, you've got 8 of the 48 parish councils to stop. Are there any that you're finding particularly difficult that I can maybe try and help with? Because they're probably, so I've got some very small ones in my ward who probably won't even understand what it's all about. Perhaps offline you can let me know which the parishes are, and I'll see what I can do to get you a complete list, Louis.
Yeah, it's not so much the list. They've all got their own different quirks, if you like, and some of them, whether it's resourcing, whether it's just office hours, or like you say, could be the size, how far out they are. They've all got the different reasons for being making it hard for me to get hold of them. I have actually been round to the ones that even we can't contact. What I'll do, Keith, if I give you a shout offline, and then we'll see if we can round up the rest of the parish councils.
I suspect one of them will be Warrington. That's a very big parish of 28 people.
Yeah.
Fair enough. That's great. Thank you very much. Thanks for the offer. That's really good. I think as well, if we can demonstrate that we've done our best, to engage as much as we can, and then obviously depending on whether or not they want to engage, then we work with what we've got, hopefully.
Worcester Water.
Yeah. Yes. Thank you very much. Thanks, Louis.
Thanks.
Going over to Alison, League Governors feedback.
My feedback today is fairly short. Firstly, I'd like to welcome the new governors. Lovely to see you here, and hopefully get a chance to chat at some point. Secondly, just to reference the away day that was in Louis' report, I found it was very useful, and I think my fellow governors who attended did. And we came away with a list of actions that we hope to take forward in due course. And lastly, I attended the regular meeting of regional leader governors, and it was very useful in that it kind of brought home the fact that out of all of the hospital trusts, we're not the only ones having issues or problems in terms of recruiting other governors. This is something that's across the board. Also, all the my fellow governors in other trusts and other hospitals, we're all trying to meet our obligations to hold hold the relevant committees and boards to account, trying to understand how the hospital works, trying to work out where it is that what we don't understand, trying to work out what it is that we don't know, and we're all in that same boat. Also, one of the biggest things that I took away from that meeting was that I'm quite privileged in having a group of fellow governors around me who we all know what we want to achieve. We're also pulling in the same directions, whereas it seems that other hospitals are having issues with their colleagues who they need to rein in. They're trying to work out how to deal with problematic issues that are raised by people putting things on social media or just not assisting in all moving forward in a favourable way that will help the residents and hospital users. And it's really, really good that every time we come together, we know what we need to achieve. We're trying to get there, and we're trying to get enough bodies around that we can do this in a good way. So yeah, that's my update.
Thanks very much. Any questions or comments about it? Okay, thank you very much. Thank you. Roxy, Health Watch.
But I'll run through it, Madam Chair. At the last meeting of the Council of Governors, we just recently met, Alison and Babs and I, and we discussed how we could, because I don't always get to attend the trust board. I would like to try and look in, but you know, with capacity it can be quite difficult. But I thought it's important to connect to it, and I did attend the previous one, and there was a very thorough patient experience report within those trust papers, and I suggested that at the very least that's something, even if I can't attend that trust board, that I look at those papers when they're released, take a look through it with that, match it against our Insight Health Watch Milton Keynes, take a view on anything any developments that have taken place. So that I did on the last one, and I've commented against that. There were only a couple of comments really, but I think around, you know, we were very pleased to see the development of the diabetes safety group. You know, there is a rather solemn piece of feedback there of a patient who came to me who very bravely said they felt they'd survived despite the efforts. And that was not necessarily about the administration prescribing of medication, but the constant battle around communication and sugar-free food, you know, managing the diabetes whilst in hospital, and around requesting certain foods and trying to ensure that they were sugar-free, and they were not, even though they said they were. So there were lots of different issues around. So we see that as a really positive move, and hope that really supports improvement in patient experience in the way they feel that they're supported with their diabetes management while staying in hospital. The other one was just around the medicines management, and just a reflection really around the important patient education to bring their medications into hospital when staying, and how we as governors and organisations like Health Watch could have some more information about providing that advanced advice and information about stays in hospital. I know there are parts, or being directed to parts of the hospital's website that we could easily signpost to, because I know there's lots of information on there, but sometimes we lack necessarily the capacity to go hunting through to get to those sections. And I did highlight some feedback in relation to things like the discharge. Like I say, we're hopefully going to be working across system on that system flow project, which will essentially, it's Milton Keynes working together across all of the services around a patient's journey to out and back in, or hopefully avoiding a readmission into hospital, and integrating that team, essentially having a much more smooth pathway so people aren't falling in these unnecessary gaps around transport windows and re-enablement, step down facilities, and just being able to get home and not having the support in place to do it. So we'll be looking at that. Really excited to work on that project. We did review the CQC Maternity Experience Survey, and I do sit on the Maternity Voices Partnership as well. So we looked at that, and that was a good discussion. We discussed the in-depth feedback around that, where we could be better, the action plans around that. So was well assured that the hospital had plans to address some of those areas where feedback was frustratingly not going in the right direction, and had a very valuable discussion about information in relation to the induction of pregnancy. So that seems to be a bit of a persistent issue around information and maternity, is how people feel they are informed and have rights and choices around the induction of labour. So that's something that the hospital and the Maternity Voices Partnership are keen to address and looking at. I'll stop there because I don't want to carry on. I think I'll say one thing that really is perhaps around the waiting times. I know the Hewitt review's just been published. I haven't had a chance to absorb its full details yet, but it does talk about hidden waiting times. And that is something that we hear a lot. It's not necessary, you know, people are waiting a long time to get that appointment at the doctor's, to see that referral, that 7-month wait for that appointment, only for it to be cancelled 2 days before for another month, for that to be cancelled for another month. And it is all too common. And not only that, people are then being discharged and having discharge letters before they've even been able to have that appointment, which is a concern as well. So, but recognising the pressures on the hospital, and disappointing that funding to support elective recoveries is not there. It's how to address that challenge is, it's a challenge. It's difficult to imagine. Yeah. It's very frustrating. I don't know if anybody has any questions.
Thank you very much. Thank you for that report. It was really interesting and very helpful how you kind of linked in, you know, the stuff with the board. It was good. Any William?
Yeah, one of the other challenges I highlight is the primary care impacts, in terms of how, you know, the experience people are having and the impact that has on the hospital. Clearly, you know, the trust can take responsibility for how primary care providers are behaving, but clearly we have to deal with the consequences, and you highlight some of those. You mentioned at the end of that about the GP access survey. Obviously, you're at an early stage of that. Could you just say a little bit more about that and when you would expect to be able to be sharing results?
Yeah. So yes, we've just closed that survey. I think we had about 230 responses to it in the end, and that was a mix of an online survey and a number of our outreach workers going along to community larders to talk to people in those areas. And I think we largely went to like Fishermead and Netherfield and Tinker's Bridge and Linford Wood and a few other areas. We've had some volunteers in local libraries as well, so they've been trying to reach out to people and feed in. I must say we've had overwhelming response from people in their, I would say 65 and over, as perhaps we'd normally expect, because they tend to be much higher users of primary care. It was quite what we wanted to really understand is get a breakdown, hopefully with enough data across practices, to say, how are you expected to make an emergency or non-emergency appointment? Is that okay with you? Does it work for you? Does it not? You know, do you find digital support helpful? And I know we've had a lot of people that responded saying they find the digital prescription services really helpful, as an example. There are other things around people's awareness of social prescribing, whether they have actually, whether they're happy being triaged by receptionists, because that's something we hear a lot, is, you know, I can't get through the receptionist, or, you know, who are they to tell me who you know, if I don't get to see a GP, and also capturing an understanding of where people have been given appointments with other professionals and whether that has met their needs, how they've been felt informed, whether they're able to kind of, if they know why they've had medication or not been prescribed medication. So gathering all that awareness. So we hope to have that report. I've given them a deadline of 14th of May. So we should, I hope we should certainly have it out by the end of May. But the idea of it is we get enough data, we can see some good practices, and actually the survey has really helped. I've had some feedback from local patient participation groups who say, actually, we think our system works really well. Will you come and have a look? So I'm going to a couple of practices who feel that they want to share what's going really well with their systems. And we've heard things about, probably no surprises, about some of the practices that, you know, people aren't having the best experience with. This is all in that kind of umbrella of the kind of integrated care board and the different places in the integrated care system trying to develop these fuller neighbourhoods. So really trying to support better access to primary care in general, helping people to use pharmacies better as well. So we hope all of that insight will really inform the development of those neighbourhood teams as well, so that they meet the needs of local residents as well.
Very ambitious. Yeah. I suppose, Maxine, just thinking about the work you're going to be doing around the flows and things like that, thinking of the last meeting when we had the Age UK presentation, which was very much around, you know, supporting on transport so people don't have to wait too long, and also that 6 weeks of support at home to enable people to stay and not, you know, so I guess hopefully that will all be factored in as well, because that seems to be like the most amazing initiative. You know, that we really should be. I know we do use it, but probably could capitalise on it even more, and possibly across the broader services as well in Milton Keynes would be really good.
And I think cogs are turning. You know, I've mentioned, you know, we were really involved with the hospital prior to COVID, and we haven't been able to kind of rebuild that relationship. And I think some of it is about visibility of who we're supposed to talk to and connect with around engaging with patients and undertaking editor review, and that's not always clear, and we've not got that pathway. And I think connecting that to you know, Alzheimer's who would like to have more involvement but aren't currently connected, and Age UKMK at the last meeting said they were feeling underutilised in certain areas, and there are just lots of gaps where I think, you know, there is something we could do to improve how we all work together, you know, the voluntary sector in the hospital and Health Watch, and look at how we address that together in terms of utilising the support that's there better. And we hope to pick a lot of that up through this system.
Yeah, I think it'd be really great. And just thinking of the challenges that we've got going ahead, you know, we've been talking about funding and things today. Actually, we do, you know, it's even more important, I think, imperative that we do work with partners and as many others as we possibly can, you know, to actually make the best that we can out of the resources that are available, whether human or financial, and you know, make sure that we get the best possible outcomes. So I think it's a golden opportunity, actually, because of necessity, that we really need to do that. Thank you.
Just picking up on your last points, Chair. I went to an event yesterday run by the Community Foundation where 3 small charities presented and talked about the costs they incur about being basically businesses. And we got to the point I asked the question, has the Community Foundation ever put together a spider map of all the organisations they support, who interconnected to who, and then look for the gaps? Because there could be gaps where 2 organisations are doing not the same thing but close. Or one example where someone had to take on a member of staff, where do they go for HR support? I know NICTA and VLP, you get questions like that up on your WhatsApp group about, can you help me? I'm looking for these special. So whether that's something that, putting all the health related organisations, the charities, primary care and secondary and tertiary care, put a big whiteboard, and I just software I'm aware that you can do it. And you put, you know, where are the gaps and what way we get maximising benefit and reduce costs and deliver more. So just a thought from basically what you said.
No, absolutely. I think there are opportunities, but you need that clear picture first, don't you, to understand what's there and as you say, where the gaps are and what we can do to bring people or groups together. Yeah, absolutely. Thank you very much. Thanks for that. Any other questions at all, Nathan? Okay, thank you very much. Item 14 then, motions and questions. I haven't had the heads up about anything. I think unless Farmay, you've got anything that's has come in? No. Okay, thank you very much. Any other business from anybody? Brilliant.
Yeah, me again, I'm afraid. One of the key parts of the new ICS system is this thing about call place. I must admit it's a strange term, I think, for many of us, but it's obviously been given a definite kind of description as part of the ICS. Now, clearly, Milton Keynes is one of those places, and we know that each place is supposed to be having a partnership board. And I just wondered if you could sort of update us as to where we are in terms of the development of that partnership board in Milton Keynes.
Have you got one?
Yeah. It's, so in Milton Keynes, because we're quite small and it's more complicated in Bedfordshire, they've created their Bedford Care Alliance, which is a subcommittee of the Integrated Care Board, and then they have these separate place-based boards. In Milton Keynes, they decided to add or amend the existing health and wellbeing board to take on those functions of the place-based board because it didn't make any sense to duplicate. I think because of that, because it retains its health and wellbeing board function, it can't be a subcommittee of the Integrated Care Board. So I must say, for me, it feels a little bit complicated but I suppose the structure is what it is, and if it doesn't work, I imagine the Integrated Care Board will review it at some point. This is my personal opinion as a Health Watch member looking in. I think it's got a way to go. There is a joint leadership team that meets separately outside of the Milton Keynes Health and Care Partnership, as it's now named, and that consists of the CEO of Milton Keynes Council, Joe sits on it as to represent the hospital. You've got Adult Social Care and CNWL, the mental health and community services provider. I believe they have someone for primary care as well. And what they have been working on is essentially that Milton Keynes deal, which is the test bed really for commissioning money, funding being given directly to Milton Keynes from the Integrated Care Board to spend on what we know we need to spend it on to improve services and reduce, elective recovery. And one of those things is that system flow. So they've set out 4 of those priorities. The meetings are only quarterly, so a lot of the work is undertaken in various subgroups, most of which we generally at the moment only involved in the system flow work. But they are looking at obesity and children and young people's mental health and diabetes. I think is that a different separate initiative? There's loads of things. Yeah. It's one of those things. Yeah. Like the world says focus on simple priorities, but you've still got to do everything else at the same time. The other stuff has to carry on. Yeah. Thanks, Maxine, very much. John, sorry, I think John, did you want to come in on this point as well? You're on mute.
Thank you for that. I'm sorry that I couldn't log in before. I had problems trying to log in, but Kwame seems to have sorted that. Thank you very much for that. Well, this is about, I'm from the public. I'm a doctor myself. This is about 2 commendations about 2 staff in Milton Keynes University Hospital, and 1 slightly negative one. I'll put in the first one first. During the recent doctor strike, Dr. Cheeto, consultant surgeon, had done a tremendously helpful job on a young man in A&E who had been waiting on the surgical list, and he was unable to access help before on the usual list. But even during the work pressures during the strike, Dr. Cheeto, consultant, that is Kyitoe, he was extremely helpful to this young man and did some surgery in the A&E, and the young gentleman is extremely thankful to him. That is one. The second is one of your
Sorry, John, sorry to interrupt. We don't normally, because this is a group where we look at services in the round and also our strategies and things like that. So, I mean, if you've got that sort of feedback, please do let us know, and then we can plug it in the right areas, because it may well be that we put this through patient experience or something like that.
Wonderful,
All right.
wonderful. Thank you.
Please, yeah, perhaps if you could let Kwame know, and then we can point it in the right direction. All right.
Thank you.
Thank you.
Thank you.
Thanks for that. Sorry, Billy, come back to
I
you.
just want to go back and ICS thing.
Yeah.
I think one of the people get very confused about the ICS system because there's so many kind of labels.
Yeah.
But one of the other key parts of it, as we know, is the ICP. So the system-wide partnership, which is and one of the vagaries of the system is that's the ICP who's responsible for the strategy.
Yeah.
The ICP then has to do something with.
Yeah.
And I was, all ICPs were required to produce them for a little while ago.
Yeah.
I just wondered where we were in terms of the LMK ICP strategy. So any information you might have about how the ICP are going to approach delivering that in the first year.
Do you know, you're almost psychic, because I actually had my one-to-one discussion with Rena McCarran, the chair of the ICB today, and we were having a discussion around how we get the partnership and the board working more closely together, so the board is delivering the strategy coming out from the partnership. And actually, she's making some changes in the governance structure in terms of us. Those two planks, if you like, of the integrated care system, actually doing some joint working. So we're very clear that the partnership gives the strategic direction, but with input from the executive side, if you like, on the board. But then the board then go away to see how they're going to deliver it. So the partnership actually does have that very clear steer for the board, and it doesn't kind of become an assurance group, So. Yeah, and she's just in the process of formulating this particular approach.
Because clearly there's a particular issue to do with kind of we're in the first year of the longer term plan.
Yeah.
So it's the first time that the organisation has been doing it. So I think there will be kind of hiccups.
Yeah.
In terms of how those work together.
Yeah. Yeah.
Yeah, I think where initially, the ICP was supposed to design a strategy, and I do sit on the Integrated Care Board as a participant member. And it became clear that the Integrated Care Board had taken over in some way to designing that strategy. And I think, unfortunately, I think that was about the maturity of the system and NHS England's deadlines around and expectations around how that strategy could be delivered. Yeah. So I don't think it worked. So there are definitely those hiccups, and I think I'm booked to meet with Rena as well. So I don't delegate the ICP, but I think it's really important we get it right. I don't think we've got it right at the moment.
No.
I think some of it. My question was, we have one of the biggest, the biggest integrated care board in the country. There's lots of people on it. And that came under some criticism, I think, as I understand at the beginning. And there has been feedback in the public section of the Integrated Care Board that actually some of the reasons why the strategies didn't develop well from the integrated care partnerships was the fact was related to the size of the Integrated Care Board itself. So I think I did challenge and say, is there something perhaps about the different, there's too many people on the ICP where some of them should be on the ICP, because I have noticed that the people on the ICP are rather low power. We don't necessarily have a lot of decision making in the system. On behalf, we can champion the voice of residents and we can feed in insight, but not a lot of us have any true power, decision making power. That's all at the ICB. So if we're going to keep with those kind of systems, we need to work out how the ICB will work properly with us and hear us and how we can fit
Yeah,
that
and
in.
deliver on what the partnership is saying.
I mean, I don't want to prolong this, but I think you've raised some very important points. I mean, let me declare something. I'm part of another ICS system.
Oh, right.
Bob. So I'm also sit on Bob's ICP. So I suppose I've looked at it from the inside in terms of our next door ICS. And I think one of the things that became very clear to me through that process was, as you say, a lot of the lead in terms of development of the ICP strategy had to be taken by ICP officers because there wasn't anyone else to do it.
Yeah.
Because the ICP doesn't even have its own secretariat. The secretariat doesn't. So I think there are real kind of challenges there, recognizing the power differences and how we deal with that going forward. Yeah. But one of the positive things which I think I'm sure could be shared here as well is that despite the fact that the lead was being taken by the ICP strategy officer, there was a lot of work done on engagement.
Oh yeah,
particularly with the voluntary sector. It was a draft, and I think that really helped in terms of producing a strategy in the end, which reflected a whole range of needs.
Yeah, I definitely. Yeah, I think anyone in the ICB would have said that engagement could have been better. Yeah. But I think the expectations again around the maturity of the system, that they did take a lot of insight from communities. They did put a lot of work in. They did gather all the existing insight that they could from Local Health Watch, from other recent reports from other areas, data and findings. So I think, I feel reassured that they did as good a job as they could in terms of engagement with the timescales and the funding available at the time.
Yeah.
And I think, the important step next is learning lessons. So all of that NHS policy doesn't just become words on a page and we just end up developing a culture that does something else. It's like, let's try and work together to ensure that that was a good work. The working with people in communities is and the legislation around it is essential. And I think we all need to work hard to make sure that actually happens.
Yeah, absolutely. And both comments you're both making do mirror what she was saying to me this morning. So I think it is very much, she's reviewed where we've got to at the moment, but it needs to be improved. So she's looking at the governments to improve that. I'm sorry, I've just noticed that Shirley put a question in around a compliment from a patient in A&E. And I think in the same way that with John, actually, if you could feed that back to Kwame, Shirley, that would be brilliant. And then we can see how maybe we might decide at this Council of Governors that we actually have a slot at the end, and have a write-up of some of the compliments, just so that people can see what's coming through. And I think it's, with all the challenges, it's good to remember there is a lot of good work going on as well. So perhaps we'll have a think about that and maybe bring it back in that way. But thanks for the question, Shirley. Keith.
Let's go on the composition of the health and care partnership that Maxine mentioned. You've got at least half of them well listed of those people. One that I'm just looking at it now, there's no representative of SCAS on there. Now, to me, that's how people get to the hospital. A lot of them, how quality leave them. I know this isn't the health and care partnership is not a hospital running. It's a Milton Keynes organisation, but it just seems strange that unless anyone's representing SCAS as there, you've got the CCG, you've got hospital trust and so on. So is
this in terms of the partnership? Did you say?
So ambulance drive in here with people and they drive out of here with people. Yeah. So I just comment that I can take that back to the chair, who is actually the leader of council, and ask whether that's something that they might want to consider in the future. I think but everything else you mentioned, Max, and the group is there, plus some others.
Yeah.
The fire service are on it, Thames Valley Police, and the voluntary sector. So they're not, you would think immediately as health and well-being, health and a partnership, but it is good to see that it's very rounded.
Yeah.
What I think the one exception I did bring it up previously at the council because it was in the community safety partnership. It wasn't represented. This isn't now.
Yeah. Yeah, I think with some of this, and because of course there's East of England as well, but this is Bedfordshire, so you know you've got the two there. But I think with some of the looking at the sort of which partners you get in on a regular basis in terms of the numbers, you know, it's growing and growing and growing. So I know there have been discussions around actually bringing in partners for certain specific discussions, because sometimes because sometimes you know you can have meetings, and for some of the partners actually the discussions really don't touch on what the services or anything like that. So it's about making the best time and use of people's time. But I think at the same time this has to evolve. So if it does seem that there is a gap, and they should be involved, then actually that needs to be revisited to make sure that they are there.
Yeah, I mean, clearly, as Maxim says, that the system needs to mature.
Yeah.
But must have been, I'm slightly concerned to hear that sort of being all pushed into the health and wellbeing board.
Yeah.
Because there are, in theory, lots of things that fall outside that. So it seems to me having something, a partnership, which is part of that. And therefore that has to have knock-on consequences in terms of operating subcommittee is something which I'm sure needs to be looked at.
Yeah. Yeah. Absolutely. Thank you very much. Thanks for that. Any other business? Okay. The forward agenda plan, and is obviously we've got that there. Does anybody have any comments or queries on that at all? No? Happy with that? Great stuff. Thank you. Thanks for that, Kwame. Next meeting is in July 26th, again at 4 o'clock. And it just leaves it for me to thank everybody today. Thank you for coming along, and thank you for all your input, and look forward to working with everybody over the next year. See what the challenges are. Thank you very much. Have a good evening. Thanks. Oh, fine. What's actually reasons?
Yeah, I have to just have more.
I think she needs a really like she does. She's the head of the she will have stuff. She doesn't have stuff. Oh, I know. They seem really trying to give me a process.